Good evening and welcome to our second Medically Speaking webinar brought to you by Grace Bible Church. So as we're waiting for other people to join, I think we will start just by opening in the word of prayer, and then I will introduce my guests who I'll be in conversation with this evening. And then, you must feel free to use our chat box to post any questions that you might have today. So we may close our eyes and pray. Father, we just want to thank you. We thank you, my God, for the opportunity to be able to minister with our skills this evening. We pray, mighty God, that you will enable us to deliver a clear and understandable message. We honor you and we give you glory this afternoon. In Jesus' name we pray. Amen.
Amen.
So thank you so much. Thank you so much. I'm going to introduce the two wonderful people that are joining me today. I'm going to start with our guest, who is Dr. Kabo Ijane, who is a urologist. I'll tell you more about him because he's not just a urologist, he's also a robotic surgeon. So we're going to unpack that a little bit, Dr. Ijane. He is a father of three, married, and only daughter Nalase Wisil. So we just want to welcome you and just thank you for your willingness to be able to join us today. I'm also joined by our own doctor from GBC, with Dr. Nhlanhla Mzlalose. We serve together in the medical team within Grace, and he also is in private practice. He's a general practitioner here in Soweto. Before we can even start, welcome to the two of you. But I really just want to thank Uma Bishop, no Bishop, for their vision, really for allowing us a platform like this. It's such a powerful platform in terms of disseminating information that is coming from experts, because doctors, there's lots of information out there. There's Dr. Google, there's social media. People don't usually know what is what. So I think this platform allows us to actually deliver a message that is evidence-based, that is based on science, that is accurate also. It's accurate information. So thank you once again for joining me. So I'm going to start with Dr. Kabo Ijane, who is our guest, to just tell us, what is a urologist? What does a urologist do before we can even unpack the topic? I think, fortunately, people know that we're discussing prostate health. But while we discuss prostate health, I want you to just tell us what a urologist does.
Thank you very much, Nolu, for the introduction. Nakambokoto for the invitation. Everyone else for who's here to listen to us. It's a pleasure for me to join you tonight. A urologist, we've been chatting a little bit about this, and I was asked to really stress it nicely that it's not an equivalent of a gynecologist to men. More often than not, when patients come to my consulting rooms, strange enough, both male and females, they'll be asking me, what are the females doing here? And the females will be there, mostly will be the moms bringing their children, their boys, their boy child. And they're surprised to see females who are not escorting anybody entering by themselves, and they ask. And my answer to them is like, guys, this is not men's clinic. Men's clinic is somewhere else. It's a urology practice. So what exactly does that mean? We are a surgical discipline over and above other things, looking at the diseases of the kidneys, the urine pipes, including the bladder, the prostate gland, and generally male genitalia when surgery is required. And the reason I stress on that is that you may have somebody who's a nephrologist who looks at kidneys also, but for dialysis and other things. So it's very important that most of the time when you want to go to the urology practice, you may go under the knife. So be very careful when you want to come there.
So you are a surgeon, you cut. You are the doctor who cuts.
I cut, guys. Of course, here and here, occasionally urologists will look at male sexual health, and they may look at male fertility, but also in the line of cutting. I'm sure Dr. Mdaluso will explain others. They are very capable of looking at things that doesn't need cutting, and then they refer to me things that need to go under the knife.
Perfect. But I have to then tell the people that you are the first African robotic surgeon. So we really just want to be like, we want to
We are on a
celebrate you
church
for that.
service. Thank you. I didn't expect that one, but
We have to celebrate our own. So thank you for
thank you.
joining us and for your willingness to really participate here. And Dr. Mdlalose, I mean, you see patients, you are the first point of contact. So while Dr. Ijane will be cutting, you will be the first person that, when patients are presenting with symptoms, they'll go to their GP first and they will seek help from there. Yeah. So maybe let's then get into our topic. So our topic is prostate health. And I think Dr. Ijane has studied the prostate better than any of us here today. So Dr. Ijane, just tell us, what is the prostate? Where do you find it, and what is it? What is its function?
Okay. It's very, very, very important question. People always mix a prostate with male gonads, for lack of a better word, male private parts, in particular the testicles. They will arrive and say, "No, my prostate is swollen," and ask them, "Okay, how do you see it?" Then they show me their private part, which is something else, could be a hernia or a hydrocele. The prostate gland, simply put, I usually say, think of it this way. Uh, Females have got the uterus inside and it get ill. Males, we've got a prostate inside and it can get ill. Does not always, but it can get ill. It sits just below the bladder, at the mouth of the bladder. So the urine tube passes through it before it goes into the manhood to go to the outside. We all are born with it. It starts developing at the age of 13. So if you are a man, you've got a prostate gland. And maybe for those who are in the know, only in antiquity, when people, we used to have eunuchs. I'm not going to tell you what is a eunuch. Those are the guys who would not have a prostate develop because they would not have gone through puberty with their gonads in place. They would have been removed before that. Any of us male who has gone through puberty, we've got a prostate gland, and it's have a simple purpose. It helps us with secreting certain chemicals, which we will talk about a little bit later, which assist us with ejaculation, which is necessary for conception, reproduction. But it also sit at the mouth, and because the urine passes through it, it can affect how we pass urine and how we experience symptoms of urination. So, in essence, it's an integral part and parcel of every human male.
Thank you so much. Maybe just to also clarify, so we had our first webinar and we're discussing cervical cancer, and Dr. Mbogota said it very nicely. On these webinars, when we are medically speaking, a spade is a spade. So people must just understand that we're not going to sugarcoat anything. Everything, we're going to call it by its name. We're going to call it by its name so that people can understand exactly what we're referring to. So maybe to bring Dr. Mdlalose in. So when people come to your, specifically our male, patients, when they present to you, what are the commonest things that they would come to you and complain about?
Good afternoon, Dr. Nodotando, to your listeners, and Dr. Ijane. We thank Grace Bible Church for this opportunity to share our skills with the community, to be relevant to the society. To get to your point, we have communicable diseases and non-communicable diseases. The communicable diseases will be those that are caused by pathogens. In layman's language, will be those diseases that are caused by germs. Your germs will be your viruses and your bacteria. And then on the other side, we have the non-communicable diseases. These are not caused by pathogens. They are not transferred to the next person. So the common communicable disease that we see in private practice will be your infections with the HIV virus. And then the second most common one that we see, it will be your TB. And if you look at both of these diseases, they are preventable. It's just the lack of knowledge that we see this prevalence of these diseases. And then moving to the non-communicable diseases, the most common one that we see will be your hypertension, your diabetes mellitus, cardiac problems, heart attacks, and then the topic that we are discussing today, your prostate cancer, falls under those. Yeah, those are the most common ones that we see.
So maybe just to understand, because I think it's an important platform, and I'm so grateful that the church allowed me as a woman to actually facilitate this conversation, because it means that we have moved past this thing of saying there are certain topics that women cannot, participate in. So I'm really grateful that I am a woman facilitating a topic like this. So in your experience, Dr. Mdlalose, in private practice, what are the trends in terms of the healthcare seeking behavior of men that maybe you could highlight for us?
Okay, Dr. Nandotando. I think in part I will be discussing the barriers to males assessing the health system. Number one barrier that we see is the stigma associated with diseases. Number two will be the male mentality. You know, we are raised as men to be these guys who do not feel pain. More when you have a problem, they say, "Indoda ayikhali, you must brother." So men are afraid to consult because of that. They are seen as lesser men. You are not man enough if you go to the doctor. So that's the other barrier that causes a man not to consult as much as we would want to. And if you look at a topic like a disease like prostate cancer, it's one of those cancers that are treatable. So if it's detected early, we can save a lot of patients. So because of these stigmas, so it becomes difficult for men to access health facilities. And then the other one is the lack of resources, especially in your rural areas. We know that some of our patients in rural areas have to catch a bus to get access to healthcare. Unlike here, at least in the township, we have many local clinics for those who don't have medical aids, and then those who can afford can easily access their doctors. And then the other thing that limits patients from seeking doctors, it's, men are providers. So most of the time they are at work. So they don't make time, or there is no time for them to consult a doctor. They wake up early to go to work. We know our transport system here in South Africa, you spend hours on the road. It can take 2 hours of your time. The other thing, when you get to work, we are supposed to be there for at least 8 hours. And then when you come back, it's another 2 hours. So 12 hours of your time is taken. And then if you take the sleeping time, so there's not enough time for people to consult. And then the other thing that will be a barrier is the overcrowding of our facilities. Many people, the environment we are in, the socio-economic status, many people don't have money to go to private facilities, so they rely heavily on the government. So we find that those institutions are overloaded with the numbers of patients. So because of overloading, the health workers are overworked as well. And then in all that, people get discouraged to consult because they know that they will be standing long queues in local clinics, so they rather seek help somewhere. And then that's another barrier that we find in men. Men, they tend to self-treat. I don't know whether there's a place called Ekwezi where they sell imbiza. So most men, when they have problems, anyway, they will go to such places and consult there instead of going to the normal health practitioners or health workers that we know. So they self-medicate, they consult to non-professional people.
Yeah. Yeah, no, but I think this is the importance of having a platform like this where we can share information that's going to empower our dads, our husbands, our uncles, our brothers, so that they can seek help quicker before things complicate. Because, when you delay, even something that is treatable can end up, becoming much more complex to treat. So let me bring Dr. Ejane back to have a conversation now about prostate. So you've told us where it is and you've told us what its function is. So let's fast forward now. You're now 40 years old. What are some of the issues that start to develop with the prostate that could be problematic? And what are some of the signs that maybe you might be having some issues with your prostate?
Yes, Dr. Nalu, I will respond to that. But just before I go on that, I want to just add one more thing on what Dr. Mdalusa just said about men and their barriers. And I'll share it as a story. Two patients of mine, one I have been treating for more than 2 years for prostate cancer, and then the other one just over 11 months. They meet in my rooms only to find that these guys here in Pretoria, there's these things called societies, a group of gentlemen who meet regularly to chat about this and that. And that in that this and that, it does not include medical issues. Because all these guys, one of them operated 2 years prior, the other one 11 years, and they were together over the weekend. They meet in my rooms during the weekend. They are surprised that they are both here, and none has ever spoken to each other about what they are going through. So the invincibility and the secrecy of not sharing with others, I don't know whether it makes us feel weak or what. You can imagine they meet almost 3 times a month, but even when the other guys spent weeks away or time in the hospital, they didn't disclose to the other one, and it happened both ways. So that's very, very important, that people should open up and be able to just chat freely and shake away the invincibility complex that sometimes either we born with or society brings upon us. Okay.
Dr. Jane, before then you move away from this point, because now you have really gotten deeper into it, and I wanted to bring it in any case. So maybe let's discuss it further. I mean, there's a case that we're just discussing about also the partnership that and the support that we require from. So yes, here we're discussing the prostate, but we want the moms, the sisters, the wives to also be part of this conversation, because that's where support comes in. And we do see that sometimes there's this secrecy around some of these topics, which doesn't help us in terms of getting the necessary help. Are you seeing some of those in your practice where, a man might be coming to you, consulting, having treatments, but has never disclosed to their wife?
Yes, on Saturday I had a patient exactly like that. So this gentleman was there for prostate cancer operation. Turned out that the family doesn't even know what he's there for. So it's very difficult. They don't want you to tell the children sometimes. These are grown-up children. I'm not talking about somebody who's maybe 11 years old or in matric and you're worried that you'll stress them. A married man or a married woman whose father doesn't want them to know that they are dealing with these medical conditions. The most interesting one also that I had was also around vasectomy. You find gentlemen coming to want to do vasectomy, and they don't even want to speak to their spouses about it. They don't want it disclosed. It's also dangerous for us as medical professions. Let's say I do such a major operation on you, and there are issues which can happen. Anesthesia surgically, you may end up now you are on a ventilator after operation. It's not common, but these things do happen. And now nobody knows about what has happened to you. You try to call family, who's the contact person, and they just think, oh, this gentleman just came in for a quick checkup, it's a minor op, and they are shocked that we're actually doing a cancer operation, which happens more often, and we experience that. So the moral of the story here to all the gentlemen, the opas, grandpas here on this platform, and please do share the word. is that we need to open up about the things we are dealing with medically. We need to open up about the diagnoses, the risk and the benefits of whatever we're trying to do. And it's very important that I insist now lately that I would want to speak to at least one member of your family for any operation that we are going to do, that of your own choosing. Because as minor as we may call it, things can go awry. And then now we are sitting up there, nobody understand. Plus, it's easier coming from the doctor than yourself. Let it be my problem rather to explain to the family, to your better half, that this is what we have found. And then you can have questions for this doctor yourself, and then you can assist your partner. You can be assisted as a male by somebody who listened with you and reminding you and having a discussion with you. So you are robbing yourself the opportunity of a supporter by not disclosing. Because now I just told you you've got a dreaded disease, and there is a possibility that you are going to need chemo, you may even need radiation. This disease could potentially be life-threatening. Your mind shut out, and you don't hear anything else after that. And somebody else will assist you with the processes. So really, really very important, Dr. Nolu and the audience.
Thank you so much. Okay, now let's maybe get deeper now into the topic of the day. So at least we've cleared that one out, that, you know what, we're here to really provide information, to provide support, and we want this to not be just a secret discussion and a journey that our fathers, our brothers, our uncles go through alone. We want to be there to support. So, Dr. Jane, just tell us then what kind of presentation can our dads, our spouses, our uncles, our grandfathers, and our brothers look out for in terms of prostate, disease?
Yes, prostate conditions are diverse, and it's not always cancer. Of course, we're all worried about cancer. However, a prostate, like any part of our body, you can get an infection. It can swell and become and have a growth inside, which is not cancerous. We call those tumors. It's benign and malignant. So what happens is that between the 30s and the 40s, it's very rare. It's extremely rare for men to present with cancer. When you see it, it's a very odd outlier. I can remember maybe over more than a decade, only 3 patients that I've seen with prostate cancer who are younger than 40, and it was very special occasions. But during that period of time, you could start to experience urinary problems with irritations within the urethra, in the penis, when you are passing urine. Some men, if they've got a low-grade infection, they may frequent the toilet. So you find that over and above the diabetes and everything else that can cause you to pee more often, prostate could do that when there is some irritation in there. And if it's really, really infected and inflamed, you can develop abscesses, which is collection of pus. Now you are really sick with high temperatures, shaking bodies, what you call rigors, you are sweating, and you may need hospitalization and intravenous therapy for that. And very sadly, some people can develop premature ejaculations. So you've always been called Long John, and then all of a sudden you are a short mile man. And that could be because now all of a sudden, over and above other causes of that, prostate inflammation can do that. So watch out for that in those decades. Generally, as we grow older, we tend to have the prostate itself is made of 2 components, broadly speaking. There is the frame, which is like any other building. You've got the foundations and the frames, and then you've got the walls. So in the frames, it's muscles and supportive collagens, all the supportive elastic tissue. And then, of course, you've got the glandular component, which for simplicity, work like a breast. It's a gland. It excretes certain things into our system. Now, despite the big size, because some people will have a small prostate and still have urine problem, the frame, those muscles, as we start to wrinkle in our face, they are wrinkling also in the prostate, and they can start pinching the urine tube. So your stream of urine become weak. You feel like you have not completely emptied your urine. You need to frequent the toilet to pass urine, and you will realize when there is a teenager next to you and you are next to them and you are sitting next to urinal, they go like, pa, and they are gone. you go like zipper, 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 and then you cough a little bit. It happened to all of us. Once you start seeing that, it's the time to start seeing Dr. Mlalose, general practitioner, family practitioners, and then they will assess you and then discuss with us, and then they'll pass you on to the urologist. And it's very important because the general practitioners and the family practitioners are the conductors of our health. They spend a lot more time with you. They look at all the other things. So it's always very good that they are the starting point, and they can give a call to the specialist. They discuss with us, and then we give advice or we share information. And then wait, by the time you come to the specialist, at least it's more directed and more meaningful to be seeing the specialist. And then, of course, the big one is that when it comes to cancer, by far the majority is silent. You don't even know you are sick. And that is where the problem is. So when it's coming to prostate cancer, the greatest number of men presenting with prostate cancer would have not even known that they have it. And Dr. Nolu Mlalose, it's where it's important to be screened. So you need to go check up before you are sick. Remember what Dr. Mlalose said, if we pick it early, so many things we can do to assist. So this is when now you have to get out of the macho-ness, get to the doctor and say, what about my prostate? And within that, family history is important. So we must start especially as Black people, talk frankly and openly about diseases that are available in the family. Breast cancer, put your male offsprings, cousins, nephews, and etc., everyone descending from you, at risk of a higher incidence of prostate cancer, even though it is breast cancer. So there is that crossover. Gentlemen with prostate cancer from which you are descending, both maternal and paternal side, passes those genes either through your daddy or through your mommy to us as their children. So that information need to be made available, because then you know that this is a profile of the diseases that are available in my family, and that will guide how soon and when you should get checked.
No, thank you so much. Thank you so much for that. And I think maybe then, Dr. Mdlalose, you've heard Dr. Ijane speak about the different, conditions that people present with. But in your practice, what are the common reasons? And also, when do you then refer to a specialist? Because I think it's very clear that not everything that patients may present with requires an operation, which is when Dr. Ijane will get involved. So maybe some of the tests that may need to be done when a person is presenting like that before they are
Thank
seen
you,
by a
Dr.
surgeon.
Nolotando. Fortunately enough, the only operation that as GPs that we do is the circumcision, and it's the popular one. So patients are not afraid to come to us. Prostate cancer is one of the common cancers in South African male. You will think that lung cancer is the common one because of people smoking, but it's first is the prostate cancer, then your colorectal cancer. So a patient will come to us presenting with the symptoms that were highlighted by Dr. Ijani. Not all those symptoms are specific to a prostate cancer. There are other causes of those symptoms. Remember, anything that will affect the urethra. The urethra is that pipe that transports urine from the bladder to outside the body. So anything that will cause an enlargement to the prostate will give the very same symptoms that are given by the prostate cancer. So what we have at our disposal, we have a screening test that we do. The screening test is a PSA test. Remember, we do this test mainly first to patients without symptoms, because when we screen, we want to catch the broader community. That's where we want our patients to come without symptoms so that we can act early. Remember, we said prostate cancer is one of those cancers that are curable. So if they have those symptoms and then now we don't know what would be causing those symptoms, we have that test that we do. It's called a PSA test. What is a PSA test? It's a test that tests the protein that is produced mainly by the prostate. The protein is found in the prostate, but it can also be found in small volume in the bladder. So we test it in the bladder to see the levels of the prostate. Normally, it ranges, but it's age specific, but we take the average. We say the normal value should be between 0 and 4.5. So that test is the one that will guide us as to whether do we need to refer the patient to a urologist, or we can assess that patient, repeat the test, and then observe the levels of the PSA, prostate specific antigen. And then the other test that we do, which is not popular with men, the digital rectal examination. Digital rectal examination, what we do, we put a finger into the rectum. The rectum is that pipe that passes feces. So you remember when Dr. Ijani described the position of the prostate. He said the prostate is at the bottom of the bladder, around the urethra, in front of the rectum, that pipe that passes stool outside of the body. So when we examine the patient, we use the rectum to access the prostate. So any trained health professional will know the feel of a normal prostate. So when we do that digital rectal examination, we try to find whether there is any nodules or any abnormalities, lumps that we can feel through the finger.
Yeah. No, thank you
And
so
then
much.
there are,
Okay. Yes, no. Continue. Sorry, I
all
thought
right.
you were
Yeah, I
done.
was saying then in all that, we don't just do a PSA on every patient that will walk into the surgery. There are guidelines because we don't want to over test the patient. A patient who present with the very same symptoms that Dr. Ijani highlighted earlier on, who is 35 years old. I wouldn't do a PSA on that patient because the risk on those patients is minimal. So we go by the guidelines. So there's a frequency, and then there's ages that we do this test. I don't know whether I can go to
So maybe,
the
yeah,
screening
yeah.
procedure, or we'll do that
No,
later.
maybe before we get there, because I think right now we are touching on two different types of patients. So we're touching on a person who's presenting already with symptoms, but there will be those people, because Dr. Jane spoke about the fact that you may feel nothing with prostate cancer. So, which is why when we speak about screening, I think this is very, very important. We're going to have other, webinars where we discuss different cancers. We spoke about cervical cancer in our first webinar, and we're very clear we are screening a person who is feeling nothing. So when we say we screen, it's looking for disease before the disease causes any problems and you don't feel anything. By the time you start feeling something, it's no longer screening. There we are talking about diagnosis. Now you are going to find out what is causing the symptoms. So I think that's very important. So by the time you go to a doctor saying, I'm feeling something, so the doctor is working you up to find out what is the problem. So that's no longer screening. But I do want to touch on screening now to say, when would we recommend for people to screen, Dr. Ijane? And I think maybe to touch more on the prostate, when the PSA, the specific antigen that Dr. Mdalose has already spoken about, to say, what is it? Because I think a lot of men on this call would have had a PSA at some point if they are, over a specific age. So you can tell us, what is the PSA? What is its use? And what causes it to rise? Because we know that it is not only the cancer that will result in it being elevated. So maybe, Dr. Ijane, can I ask you to just educate us on that?
Okay. Thank you, Dr. Nolu. I commonly say prostate specific antigen, probably colloquially, we should just be calling it prostate specific protein, because the word antigen tend to confuse a lot of people. And all what it means is that an antigen is a protein, but it must have certain chemical activities in the body, which are what we call physiological, which are normal functioning of the body. So our prostate gland, which I did mention earlier, and Dr. Mdlalus also alluded to, is that this PSA, it's specific to the prostate gland. It's a chemical that is secreted from the gland part when I spoke about the frame and the gland. And its job is to make sure that when we ejaculate, it's sort of a coagulum, condense like. That's a coagulum, condense like. If you took an animal like a rabbit and they don't have prostate, they ejaculate bullets. So literally, when they shoot, they are shooting. It's pellets. As mammals, because of the prostate, we emit a condensed like substances called coagulum thanks to the PSA. This very same PSA, it doesn't mean you are sick. It's there in all of us, as Dr. Mdlalus has alluded. So, depending on whatever age you are, and of course, certain activities, it could be raised above the normal for your age. And generally speaking, I'm not going to go into what age must have what. That's a little bit superfluous. But within your age category, because usually that information is readily available there. If your PSA then is raised, it says that we must check that is there a disease process, or is there a simple explanation why it could be. There are other things that are mentioned, from things like ejaculation, things like instrumentation. If you've had any other procedure around the prostate, instrument through your urine pipe, if you've got an infection in the prostate, like I alluded to, we call it a prostatitis, that all will raise your PSA. And then, of course, if there is cancer developing. So what is very important to remember is that, like Dr. Nolu has mentioned, when you arrive and you are sick, we are making a diagnosis and an examination. And I want to also highlight the fact that a digital rectal exam, as much as most men feel violated, it's more in our head and what we think about it. I invite you to go and please ask to sit in when Dr. Mbokoto is doing a pap smear on your beloved. And you can see that we have it very easy. You will come back and say, "Now I can take that prostate examination." That digital, it's nothing compared to witnessing a pap smear being done. So
But
it is
I must laugh about that, Dr. Ijani, because I remember when I was still a young doctor. Can you imagine now asking an elderly man who's the age of your dad to say, "Okay, can you turn around, Baba?
turn
I
around,
need
please.
it's uncomfortable." But our mothers, I mean, go through this every day. You know, they go in and they are examined because the cervix is also equally hidden there. So thank you
And
for
here's
just
another
highlighting that.
very important reason with that, Dr. Noli, is that there are subtypes, certain subtypes of prostate cancers, which will not have a raised PSA.
Yeah.
So the
Yeah.
fact that your PSA is normal does not necessarily mean entirely that you've been okay. And especially a category of increased body mass index and something called neuroendocrine cancers, which are rapidly growing and they destroy the glands so quickly. We may be able to make the diagnosis solely on a digital rectal exam, where the prostate must feel smooth, like when you were touching the tip of your nose. And then if it's any hard like a knuckle, it's a little bit advanced, and anything in between, as you can imagine. So that's the necessity of that. Then we come back to what we call screening. Screening is that, okay, you've been into this seminar, you've never had your prostate checked, and you are above the age of 40, or you've just celebrated 40. I usually say, have your 40th birthday, enjoy it, and then spend a few months just letting it sink and then see Dr. Mdlalosi. Don't come to me on your 40th birthday and then say, no, life has begun. They said so. But around that area is very important. We need to get you checked. So I will recommend that online we've got South African guidelines, because there are many guidelines in the world, from the NICE, from the Americans, from the Europeans, and the South African universities and our leading experts within prostate cancer, together with the cancer foundations. They've put the guidelines, and they were updated last year and published in May, and readily available online for everyone to read. But what is in there? It's a rough guidelines and a separation that for an African man, we tend to present earlier, maybe with an aggressive cancer earlier than compared to our peers. And because of the reasons that Dr. Mdlalosi alluded to, some of us will only reach the doctor too late, be it lack of resources, access, etc., etc. So generally held, because we still don't know, all of us, we don't know the full history of our families. From the age of 40, just get checked. If you are in the know-how and you know there's no breast cancer, you know there's this, and you can do genetic testing, maybe you can wait to 45. But as a general rule, to be all safe, get checked from the age of 40, and then you'll be advised on how to go, because we will assist you with the further details. And then the frequency of that checkup will be determined by the findings and the PSA, and it could be maybe 2 yearly, and sometimes we can even say maybe 3 yearly or so. Let's say if I see you at 40 and there is nothing, I'll ask you to come back at 45, and then from 45 I will then see you more often. But if there is breast cancer at home, there is cancer of the prostate at home, then I will want to see you every maybe 2 yearly or yearly, depending on the PSA testing, provided you don't have symptoms. And why I add this, it's also very important that, because sometimes it's not very cheap to go see a specialist. And then you find that patients will have seen a doctor, PSA is done, and then you see a specialist, and then you change. Now you end up doing PSA all around without anybody watching what is the trend of your PSA. And the reason for that is because we've got so many laboratories. There's the big three, which are easily accessible online, and you can get the results very easily. But then you've got another fourth one, which is coming, and then many other laboratories, which are startups, and they are supported. But for me, sitting in my practice, it might not necessarily be easy to get the results from Dr. Nolutando's practice. And therefore, I'm not even aware that your PSA was done recently. When I do it, I'm not able to compare the trend. I keep emphasizing, keep and have a trusted family doctor, general practitioner, who watches these things for us and say, Dr. Ijani, this PSA is creeping up at a pace that I don't like, because that also could be a red alarm. And then over and above that, we will then add a digital rectal exam. We may need to do radiological testing. They are not always indicated, but we may need to do radiological testing. And even that PSA testing, there are subsets of PSA that we might need to look at, which will guide us. But that's when now you need me to walk you through the guidance of that. As a summary, from the age of 40 as an African man, visit a doctor, even if you're not ill, get profiled, get tested, get a PSA, and then you may be seen in 5 years or shorter. From 45, 2 yearly, and then we carry on like that. As far as when do we stop testing you, it depends on many other factors, but age is contributing, and the general health. So if we think that, and we're not playing God here, but medically speaking, if we think that your life expectancy is less than 10 years, and it's not easy to calculate, but sometimes it's very obvious. You've got severe heart failure, you're short of breath when you are sitting, you can't even comb your hair, then we're not even going to test your PSA unless there is a reason. So don't be surprised you arrive and we say, I'm not going to look at your PSA. You say, this doctor, one moment he tell me to get tested, the next moment he send me away. We're profiling that because of the risk and the benefits. And if I think as a specialist that the test and the screening will benefit your health, yes, then we definitely do it. If we think that there are other things that are eminently threatening, immediately threatening to your life, those need to be attended first, and then we will look at this, unless you've got severe symptoms, in which case it's diagnosis and treatment. So that's very important.
Thank you so much. I'm going to try and bring all this information together. So
just before Sorry,
Sorry.
Dr. Nunu, just
Yes,
before you
yes,
proceed,
yes,
just
yes,
wanted
Dr. Dula.
to summarize everything from the primary health point of view. When the patient comes in, we have just highlighted that this cancer is common in Black African male. So, number one, we would like them to be tested early. The number two, Dr. Ijani has highlighted that if there's a family history of prostate cancer and breast cancer, those patients we also want to see them early, especially those who have first degree relatives who have breast cancer and your
Prostate.
prostate cancer. So those we will want to see. And then number three, on a primary level, like he highlighted, the frequency depends on the age and the level of PSA. So we would like men to come more often to consult the doctor. We want them to follow the guidelines that he highlighted, especially to monitor the elevation or the trends of the PSA for us to take further action in the management of the patient. Yes, thank you.
Thank you so much. You've really just summarized it nicely for me. I wanted to also just say, we've spoken about a person who is presenting with symptoms. So we say, go and see a general practitioner, let the general practitioner sort you out, figure out what's going on. Don't wait with symptoms. Regardless of your age, if you experience any symptoms that are not normal, please go and consult. And then we're speaking to our dads, our spouses, our uncles, our brothers over the ages of 40. We're saying if you are a Black African, there's a higher risk of you developing prostate cancer. So there's this racial predisposition to prostate cancer. Please discuss with your doctor. So the guideline is very clear. It says, do this in conversation and discussion with your doctor. So don't just go to some small corner place and do your PSA with no one monitoring you. It is not ideal. So we want you to be informed, firstly, about why you're doing your PSA, and then go and see your doctor, who is going to have a discussion around the pros and the cons of screening, and also the benefits and potential harms. So it is very important. So this is a person who feels nothing. So you're not presenting with anything, you are going there. But Dr. Ijani, because at Grace Bible Church, we not only have Black African males, there may be somebody here who's not a Black African male and like, okay, they're not talking to me.
They're not talking to me.
So it's important to highlight the reason why we are speaking mainly to Black African males. It's because of the risk that is associated with just being that gender and being that race, and also the aggressive nature of the prostate cancer in that population. But we're not excluding others. So if there is somebody else who's not a Black African male, what is your recommendation to them?
Yes, thank you for the correction. I got carried away with blackness, and apologies to all the other audience, dear South
Yes, we
Africans.
are
My
a rental
sincere
nation
apologies.
here.
Yes, so this cancer is a racist. Sorry, I'm kidding. That was on the last jest. From the age of 45, it's very important. Do visit the doctors. Also, do get profiled. You find that as we grow older, the incidence kind of like is the same. You're going to find that most of the research done in the South Africa tend to align mostly with the European Urology Association. Of course, the Americans do also have their guidelines. And the reason for that is probably just because of Britain and the history that we all know. But they also do have their own little British on the side. But if you look at those, that data was largely missing of the Black African, which is why it was highlighted as a particular standalone, and not necessarily excluding other racial groups, and they are all covered there. Whether if you look at the research done in South Africa, It covers the late Prof. Haynes, may soul rest in peace, did a lot of research on prostate cancer, colored communities in the Western Cape and everything like that. So all that information is available and readily referenced there. But from the age of 45, everyone else, just make sure that at least you visit your doctor once, get checked, and then you'll be profiled. And just to overemphasize, the reason I said for African men is because as early as 40, if there's breast cancer, first degree relatives and everything, we do see an aggressive cancer in younger African men. I've personally operated maybe at least 50 plus guys between 40 and 45. Most of them, they came for late circumcisions. They just say, okay, now everyone is driving MMC, I'm going. And they arrive, then I'm like, okay, while we are talking about MMC, let's explore this. And then you PSA is 12. You check this is that, you check this is that. So we do find it for real. And for every other man from the age of 45, follow those guidelines, see the doctor. The doctor is going to discuss your risk profile with you. And depending on your risk profile and the result of your PSA, you may be seen annually or biannually. And it is a very individualized consultation. And this is the reason why. Your risk factors, who you are born to, your habits, your body habitats are all contributing factors to your unique situation. It's also the same when you are already diagnosed of cancer. One of you could have a very low risk early cancer, it is prostate cancer. The other one could have a very advanced prostate cancer, which is still localized, and the other one could have a cancer that has migrated to other parts of the body, and it's still prostate cancer. Okay. So don't make the mistake of saying that, why are they doing this for them and they're doing this for me? It's really individualized based on your profile, both on your risk factors, and then also on your understanding and acceptance of the risk benefit of the treatment.
Thank you so much. We've got 9 minutes left and I want to maximize on the 9 minutes. So maybe firstly, you know, when you use acronyms here, people will be like, well, the doctor said MMC, what was that? So it's medical male circumcision. So it's a circumcision. So Doc, I want us to help our fathers and our spouses, our uncles and brothers here, because they would want to know, how do I improve my prostate health? What can I do to prevent some of this? Is it all doom and gloom? And can't I, you know, influence the course of this? So that's the first thing. And as you are addressing that, please also touch on the importance of managing umkhaba. I want us to talk about umkhaba and why umkhaba is not so sexy sometimes, because medically
okay.
there could be problems.
There are, if you listen, while you've been listening to what we've been discussing throughout all this, the three of us, is that prostate cancer happens sometimes largely just because you are male and you've got a prostate gland, full stop. That's one reason. And there is not much that you can do for that except to get checked. And there are other things that you can influence. If you are born to family and there's prostate cancer in the family and there's breast cancer, and you are a male and you are over 40, you are at risk. And not much you can do except going for screening, and then we will assist, as we've already alluded to. And then there are things that tend to affect all cancers, including prostate cancers, and those are called habits. Remember, Dr. Mdalusa said communicable, non-communicable, and then there is something we call diseases of lifestyles, and that's where probably the cover will come into place. So the disease of the lifestyles mean that even though I know this is the platform based within the church, there's still issues of human beings being within the community, smoking, and smoking. And this goes for all cancers, including the prostate. So those of us who are smokers, it would be nice if we can cut down and eventually stop and try to stay away from that. And of course, including substance abuse, drugs, they affect your immunity. People with suppressed immunity who sometimes are in denial and they don't want to take their ARV, antiretroviral treatment for HIV infections. When your CD4 count falls lower, all cancers flares up, including that of the prostate, of course, and all other related cancers. And then, of course, I know we are in South Africa and we have a National Braai Day, and I'll pause deliberately. We eat cows, emzini, we kill, we eat the choco, we enjoy our red meat. But with all the red meat, there is a slightly higher risk as you were compared to if you were taking fish-based diet. So, in as far as diet is concerned, that's very important. We need to not eat red meat every day, especially bride, charcoal bride, and every bride. And when we're supposed to, those of us who are, those amongst us are married. I almost say those of us who are not married. Those amongst our audience who are still single and are lazy to cook and they want to braai quickly every day and they braai meat, the fire is always raining in your boma, that can increase your risk a little bit. Processed meat also. So those are very, very important. So we need to watch against that. And then we need to monitor the weight. And I'm being very sensitive to the fact that not everyone who's got issues with body mass index is because they are not necessarily disciplined, inverted commas. There could be many reasons from medical to psychological and to just poor bad lifestyle choices. But the first thing you want to do for yourself is to try to maintain a proper body mass index as much as possible. And the reason for that is because when we've got an increased body mass index, not only are we at risk of high blood pressure, sugar diabetes, high cholesterol, premature death from heart attacks, we are also at risk of aggressive prostate cancer early on in life. And this is also very important. That big mukaba with our adipose, the fat around the tummy, it wastes our testosterone. Now, testosterone is that chemical that comes from our testicles. I was given carte blanche to call a spade a spade. It comes from our testicles. It's important for our libido, sexual desire. It's important for our erections. And when it goes to fat, it's breaking down to something called estradiol. So your testicles are working overtime to try to keep the marriage going and your duties that the pastors will tell you about as a husband. But now you are wasting that away on that tummy because mommy is cooking so well. So also the ladies who are still, I'm not saying only women cook, and nowadays you have to be very careful what you say. But all the chefs, the cooks in here, while you are nicely fixing them, you also remember that we also want healthy eating so that you can control that mukaba. If you cook so well for mukaba and the mukaba become too big, you may be a bit lonely there in your marital suite. So those are very important. Lastly, on that, doctor, is leucopene, which is a chemical that comes from tomatoes. Usually well concentrated within tomato sauce. So we do need to eat tomato sauce regularly. Please don't drink it and then until you can't take it anymore, but eat regular portions of tomato sauce because of the leucopene. With ejaculation, I know it's written up a lot that you must have so many ejaculations, 21 ejaculations per month, wara. The science there is weak, but of course, if you are busy and healthy that way, I think you're already doing well. So I'm not shooting it down, but I will leave it to talk another time when I'm invited to talk about something else. I will revisit the story of ejaculation and prostate health.
Hallelujah.
I get carried on.
Hallelujah. I wanted to maybe just because I think that's good. I think, and also physical activity. I think we will maybe address just a healthy lifestyle overall because it affects many other aspects of health. But thank you so much for that. I don't know, Dr. Mgalose, if there's something that you wanted to add to that.
What I wanted to emphasize on is that what we are dealing with here is things that are preventable, and they are heavily linked on lifestyle, like as Dr. Ijan has highlighted. So I will emphasize that people must get to the habit of screening. People must be physically active so as to reduce overweight and obesity problems. And then lastly, I think men need to start now by discussing and be open among themselves in discussing the issues that affect them. issues of their health, specifically. I had a friend who passed on with a heart problem. He had congestive heart failure. And the reason that he passed was largely to how people around him were treating him. He stopped going to the doctors because men, it's in our nature to make light of serious issues. So he will be laughed at because of, heart failure causes swelling of limbs, both limbs. So he was at a stage where he was unable to put shoes. He used to wear sandals because of the size of the feet. So people would make fun of him. He ended up stopping to consult. He didn't get the help that he needed, and he ended up passing away. So as men, we need to be serious about these issues, discuss them, and don't think that going to a health facility will demasculate us or make us lesser of a man. Yes, thank you.
Thank you so much, Dr. Ijane. I have to just throw in a few questions from the chat before we close. I know we are right on the dot at 6, but there's one. So people want to know, are there any supplements that they can take? Is there anything that they can take to just improve their prostate health? And then there's an important point that we have not covered around prostate cancer treatment and erectile dysfunction. And I think there are certain people who are on this call who have gone through prostatectomies, meaning the removal of the prostate as part of the treatment, and now they are experiencing erectile dysfunction. And so those are the two things that came. And also, I think you have covered it slightly, but maybe you can just you can emphasize it again. People wanted to know if abstinence does improve prostate health. I think you spoke about the many ejaculations. So please, before we close.
Diet first. On dietary issues, like Dr. Mdlalus has mentioned, Dr. Nolu and the audience, healthy eating is very important. A lot of things is written in the internet. It's available on every search site that you may get to. I emphasize lycopene because research was done and there's some level of evidence to assist with that on antioxidants. But if you go, they'll talk about nuts, watermelon, pumpkin seeds, prostacare, South African star grass, saw palmetto, beru. I can keep going. The problem here is that we don't have good evidence supporting that for me to sit here and say, when you take this medically, this is what happens to you. However, most of those, if you look at that, it's like healthy eating habits. So stick to what we've been emphasizing, healthy eating habits, some exercise program, and general also mental health, good mental health, so that we don't end up with depression and overweight. If you're overweight, I can blame you for overeating, not for other stuff that you're struggling with on the side. So do not ignore mental health. It's very, very important. Treatment of prostate cancer is a very broad, detailed discussions, but broadly speaking, cancers can be treated with surgery, with radiation, and with chemotherapy. Chemotherapy tend to be reserved for cancers that are advanced. And in particular to prostate cancer, you have options of using operations and or localized contained radiation called brachytherapy. I like to call it the rice crystal treatment. So that could be used for that. And the discussions on that are individualized and detailed. However, generally speaking, because of the reasons that we mentioned earlier, and very importantly, what I probably missed to inform you is that think of the prostate gland as a small little narky, an orange. It's got a peel and it's got the content. Now, if you're holding it on your hand, and then on your left side at the bottom of that orange, that will be at 7 o'clock. And on the right side at the bottom of that orange, that will be at 5 o'clock. Those two areas, the nerves that assist us men with our erections coming from the back, they are attached to the skin of the prostate on the outside. And then they run on that prostate surface and they curl on it. Just imagine the orange. and then joining the carrot as the penis stuck on the orange on the other side. And they will then curl around it and then join the penis. That's how we are built. So now you can imagine if I'm operating you there, if I'm putting radiation seeds there, I am going to affect erections. The degree to which these erections will be affected, it depends on the stage and the subtype of treatment that you might be getting. However, things are going to change sexually, and there are solutions that could be individualized. It does not mean that all of a sudden, if you've done a mode of treatment, you are not you are less likely to experience symptoms as compared to if you've done the other mode. I do all these operations, brachytherapy, laparoscopy, open surgery, robotic surgeries. Our experience is that your erectile function before treatment is very important. The degree of local advanced disease. Can I be able to do bilateral nerve sparing, meaning saving both sides of the nerves, or only unilateral nerve sparing could be done? What other comorbidities do you have? What age do you have? And how healthy are you? All those things affect largely the outcome of where we're going to end with your erections. Then there are rehabilitation programs from medications to vacuum pumps to psychotherapy that are also going with this. Hence the need for the wife, for the partner to know about what you are going through. With urinary continence, also very important. Remember, I mentioned that the prostate passes, the urine tube passes in the center of the prostate to join our penis. Therefore, when it is removed, the urine comes directly from the bladder into the urethra, where else in the past there was dumping by the prostate. Now the prostate is not there. So majority, depending on whichever mode of surgery, you may have either burning and irritation if it was radiation and you frequent the toilet more often than you used to, or you may have what we call stress urine incontinence. So when you exert your tummy, coughing, sneezing, lifting something heavy, urine may leak, and there are processes and treatments that we put in place to assist with this. So it is a very involved program with physiotherapy, counseling, partner, Kegel exercises to recover some of these programs.
Yeah.
On the contrary, if you avoid treatment and say, I will leak urine, if the cancer advances, it will not only threaten your ability to pass urine, but it will threaten your life. So this is where we talk about informed consent. We have to sit with you and your better half, discuss the disease, profile it for you, weigh the risk benefit of whatever treatment modality you may choose, and then enact it and then assist you through the process with the treatment. That's very important.
Wow. I think in summary, information is power. But even when people are going through some of these complications or the side effects, or the complications or side effects from the surgery, there is something that can still be done. I mean, there was a question around a testicular lump. Unfortunately, today we're not discussing testicles, but I think we definitely need part 2. There is more that we should be unpacking here, Dr. Ejane. It looks like you need to come back and share more information here. And I think it's important for us to have these platforms where people can ask questions freely and be able to get information that is accurate from experts like yourselves. I think I am going to...
I will be available for round 2 and maybe even round 3.
Yes, we can do round up until, we've unpacked.
We'll do the rounds, Dr. Mzalusa.
Just to add on that, Dr. Nulu, this topic is so important, and what it highlights is very crucial. But at our church, we are fortunate because we have this health drive. Like in Vetpoki, I know next week we will be having one where we will be doing screening for males, for females, even for children. We'll be offering immunization. So I think this platform and what the church is doing for the community, we are actually being relevant.
social relevance, right
To the
right
mix,
there,
yes.
right there. No,
And
it's honestly super amazing. We are so grateful to the leadership of our church from Uma Bishop no Bishop for just allowing us to use this platform to educate people. You cannot thank them enough, and I think we have come to the end of this webinar. I mean, there's quite a lot that we need to unpack, but as you heard, Dr. Ejane is really willing to come back and have another session with us where we can unpack more of this. So we just want to say thank you for those who have joined. Thank you to the leadership of the church, and thank you to the Almighty for enabling us to be able to unpack this information the way we did. To him be the glory. Thank you so much. Have a